Shall we start?
Yes, sir. You can.
I'm not able to see my presentation. Yeah. Are you able to see PPT?
Not yet. Not yet.
I think Dipen has to share it.
Dipen, please look into it.
Sir, you can share. Just click on the share screen.
Share screen.
Yes, sir.
Now, is it visible?
Yes, yes, yes.
Good evening, all. Before starting my presentation, I would like to thank Dr. Prahlad Kotkar, President, and Dr. Sachin Chandolkar, Secretary, ISA City Branch, Aurangabad. They have given me this opportunity to share my experience with you all. This is the outline of my presentation. Sachin, as Sachin already told that you may have read that case which I have posted on some WhatsApp group. So we will first talk regarding that case. Then we will see the Indian statistics regarding the CPR survivals. Sachin actually suggested me to talk regarding beyond CPR. So it made me think, at least for last 18 days, what really lies beyond CPR. And that's what I'm going to present today. This was a case of my young friend who had no comorbidity. Actually, I saw his fingers with clubbing, so I advised him to get investigated, and we found that he's having polycythemia, but we could not find out the cause. He has no addictions, and just few days before this event, he had a knee injury for which he was taking diclofenac and paracetamol. On the day of event, I was doing yoga at my home, and I got a panic call from his wife, and she told me that he is having nausea, vomiting, and sweating. So I initially thought that this is some sort of gastric upset, but on further inquiry, my friend told me that he is having heaviness of chest, his BP is high, and he is sweating profusely. So I thought this looks an emergency situation. I told him that get ready and I will come to pick up you so that we can go to the hospital. When I rushed to his home, on the way, I got many phone calls from his wife, then from his father, and with every phone call, I was also getting panic because the prognosis of the event was not in right direction. When I reached at his home, I saw that he is lying dead. There are no signs of life. There was no pulse. He was not breathing. His eyes were popping out. So though I was emotionally, it was a very emotional and intense moment, but I started thinking that I should act instead of thinking what will happen if I do not do something for him. So I immediately started compression only life support. Actually, I was having anesthesia kit in my car, so I could have easily intubated him, but there was no help to ventilate and at the same time give chest compression. So I thought that it is better to shift him with compression only life support. So with the help from relatives, we shifted him to the back seat of my car, and I continued CPR only compressions only life support in that moving car. We reached in a United Sigma hospital in another, I think, 5 to 7 minutes. As I am working in United Sigma hospital since its inception, I was knowing each and every staff there in the casualty, which helped me a lot. After reaching there, the staff and RMOs took over the chest compression. I immediately intubated him. Nurses attached the monitor, and we noticed that he is having ventricular fibrillation. Now, at this point, I was thinking, what is the cause of this ventricular fibrillation? Either he could have MI, but as there were no comorbidities, he was not having any addiction. So I thought MI is a very less likely. So he had knee injury only 8 days back, and for that he is taking diclofenac, and also he is having polycythemia. So I thought he probably developed DVT, and because of that he had pulmonary embolism. So I was thinking in that direction, but fortunately cardiologist and my anesthesia colleagues reached there immediately. And when cardiologist did the echo, he said that pulmonary embolism is ruled out because RARV is normal. So he immediately said that as this ventricular fibrillation is not responding even to 15 DC shocks, we should thrombolize him. So immediately tenecteplase was given, and with tenecteplase reaching his heart, immediately the rhythm, ventricular fibrillation, converted to the sinus rhythm with massive ST elevations. So cardiologist said that he is having massive anterior MI. So with that diagnosis, we decided to shift him to cath lab. Now, whenever you see a patient who is having anterior or myocardial infarction, then his chances of survival depends how quickly that patient reaches to cath lab, and we do angiography and if required angioplasty. So in this case, I actually inserted central line and shifted inotropes from peripheral line to the central line, and then shifted him to cath lab. After doing angiography, we found that the left anterior descending artery is 100% blocked. So immediately, with the consent from relatives, we performed the angioplasty. So in this case, the door to balloon time, which is the time from when the patient reaches to casualty till the angioplasty is performed. So this patient was very fortunate that the door to balloon time was less than 60 minutes. Initial 40 minutes we did CPR to him, and in another 20 minutes angioplasty was done. With the stent in his coronary artery, immediately the inotropic requirement decreased, and hemodynamically he becomes stable. So we shifted him to ICU for elective ventilation and monitoring. At this point, we were not very sure about his neurological status, because initially I did not ventilate him. I give only compressions, and without ventilating, I shifted him from his home to casualty. So I was very skeptical. I was anxious to know whether he will have normal brain function. But fortunately for him as well as for me, he was awake and he was obeying commands at around 4 p.m. in the evening. So then we stopped the sedation, we stopped paralyzing agents, and he recovered rapidly. But as you know, after any cardiac arrest, patient will have post-cardiac arrest syndrome. And due to this syndrome, the liver functions and kidney functions were derailed. But fortunately, he responded well to the treatment and he recovered rapidly in next 5 days. Only complaint at the end of 7 days was that he is having rib pains and the chest pain because of the aggressive chest compressions given by me and my colleagues in casualty. Fortunately, he was discharged on 7th day of admission. Here is his picture while discharging. He is sitting on the wheelchair, but neurologically absolutely intact. He was remembering each and everything except that 5 minutes when he was unconscious. But fortunately for his family and for me, his brain function was absolutely normal. But in India, this is not the outcome in all cases. As we know, almost 70% of cardiac arrest occur at home, and 90% people who had cardiac arrest out of the hospital will die. As an anesthetist, we know that even a minute delay in resuscitation will decrease the chances of survival almost by 10%. If you compare the statistics with United States, where only 150 patients die out of 1 lakh cardiac arrest, but in India, almost 4,200 patients will die who had cardiac arrest. And why this is happening? Why the CPR is not successful in India? There are many reasons. The first one is the Indian population majorly resides in rural area. Our illiteracy rate is very high. Emergency medical services are not well developed even in metro cities. We don't have enough trained persons. We don't have automated external defibrillators. I think at some airports, these external defibrillators are available, but the crowded places like malls or railway stations or bus stations, we don't have these automated external defibrillators, as well as the availability of trained person is very scarce in India. Then our cultural beliefs prevent mouth-to-mouth rebreathing. So these are the reasons because of which CPR is not propagated in India, and many patients are dying only because they don't get initial COLS or CPR. So to tackle this situation, Indian Society of Anesthesiologists have given interim practice measures considering our country's diversity. So this compression only CPR is as effective as conventional CPR for cardiac arrest at home, at work, or in public. And this adult COLS is so simple, it is easy to remember and can be performed by even a minimally trained person. As you all are anesthesiologists, I will not go in detail regarding the steps of COLS. You know the sequence. But what happens once the patients get COLS or a basic life support after arrest? Usually, these patients will have a return of spontaneous circulation if adequate CPR is given. Then these patients will be admitted in ICU, and if they are fortunate enough, they will be discharged from the hospital. But many patients die, and the causes are brain injury, myocardial dysfunction, multi-organ failure, and the metabolic causes. Brain injury is the major cause. Almost 68% patients who get out of hospital cardiac arrest and 23 patients in hospital cardiac arrest will die because of brain injury. So brain injury is the major culprit behind death of these patients. As you all know, once patient had cardiac arrest, the brain will not receive oxygen, and coma and related disorders of arousal and awareness are very common presentation in post-cardiac arrest brain injury. Cortical areas are highly vulnerable to hypoxic ischemic injury. Some patients who regain consciousness but will have significant neurological impairment, myoclonus, and seizures. This is the pathophysiology where impaired cerebrovascular autoregulation, cerebral edema, and post-ischemic neurodegeneration will cause brain injury. Clinically, it will manifest with coma, seizures, myoclonus, cognitive dysfunction, or the persistent vegetative state. And the potential treatment is therapeutic hypothermia, early hemodynamic optimization, airway protection, and mechanical ventilation. So when Sachin told me to have talk regarding beyond CPR, so he suggested this title, Beyond CPR. Then I was thinking what actually lies beyond CPR. Then with my own experience, I can tell you that beyond CPR lies the quality of life and the neurological outcome. Even if a patient who had cardiac arrest either in hospital or at home, if he survives and he is not neurologically intact, then it doesn't mean to that patient or his relative that life is very miserable. So as an anesthesiologist, we should see that these cardiac arrest survivors will have a very good quality of life, and this quality of life will depend mainly on the brain function. So we should try our level best to have the normal brain function after CPR. So what we can do to have this normal brain function? So there are many strategies to have a better neurological outcome. These strategies are related either to ventilation, then cardiac stabilization, related to blood pressure, blood sugar, hypothermia, then anticonvulsant therapy. There are only few drugs which can have some neuroprotection in patients with cardiac arrest. So let's see these strategies one by one. Usually, once the patient had a cardiac arrest, anesthesiologist or some physician intubates the patient, we try to ventilate that patient with 100% oxygen. But in these patients, this 100% oxygen will worsen their neurological outcome. Our aim in these patients should be to have saturation of around 95%. We should not aim for 100%, and we should adjust FiO2 according to the saturation of 95. Hyperventilation is not a good strategy in these patients. We should aim for normocarbia. So how we can adjust ventilation according to the PCO2 level? For that, we can, as an anesthesiologist, we are regularly using ATCO2 in operation theater. Same ATCO2 can be used in ICU settings, so that we can ventilate patient adequately and not ventilate him overzealously, so that he will have hyperventilation. We need to do arterial blood gas regularly, so that we can adjust FiO2 as well as PCO. If these patients are having ST elevation myocardial infarction as per ECG, then these patients are to be subjected immediately to the angiography, and if required, angioplasty is to be performed immediately. If door to balloon time is then less than 90 minutes, then many studies have shown that this time will save their myocardial muscle, and hemodynamically patient will be stabilized very early. If patient's heart is normal, then to maintain the normal blood pressure, we have to optimize his right heart filling pressures with the use of IV fluids. The target CVP is around 8 to 13 millimeters of mercury, and these patients may require 3.5 to 6 liters of intravenous fluids in first 24 hours. We can use appropriate inopros to maintain the blood pressure. We should not aim for very high blood pressures. Even a mean arterial pressure of around 70 to 80 will be more than sufficient. Hyperglycemia is very common after cardiac arrest. Whether these are patients are diabetic or non-diabetic, but invariably these patients will have hyperglycemia. So we have to treat this hyperglycemia with insulin infusion, and our target blood sugar concentration should be around 150. We should not use steroids routinely in these patients, and steroid use is not recommended. Preclinical and clinical evidence strongly supports mild therapeutic hypothermia, and we routinely don't use hypothermia, but in cardiac cases, many times we need to cool the patient so that we can have total circulatory arrest. So it is not a very difficult thing. Even we can keep ice bags around his head, and we can cool the patient. So with patients coming to your setup, we can cool these patients to 32 to 34 degrees Celsius for initial 12 to 24 hours. And this will improve their neurological outcome. If hypothermia is not feasible, or if it is contraindicated, then at any cost you should prevent pyrexia. The risk of poor neurological outcome will increase with each degree of rise in body temperature above 37 degrees Celsius. Prolonged seizures are common in post-cardiac arrest patients, and these seizures will further increase the cerebral injury. So we have to treat these seizures promptly and effectively with benzodiazepines, phenytoin, propofol, or barbiturates. Clonazepam is the drug of choice for the treatment of myoclonus. all these drug can cause hypotension. So we have to use this drug as per doses and cautiously. And if required, you can add inotropes, as I already mentioned. There are not many drugs which are found to be effective in neuroprotection of these patients. But as an anesthesiologist, we all are using magnesium sulfate. This drug, apart from having antiarrhythmic properties which will help to stabilize his heart rhythm, but it, in combination with hypothermia, it will also protect his brain. So if these patients, if they are having adequate urine output, then without any fear, you can use magnesium sulfate in those patients so that we can salvage their brain function. Now, what we discussed till now was regarding the patients who had arrest outside the hospital. But as an anesthesiologist, we see many patients are arrested either in ICU or in casualty or in ward, or unfortunate events also occur on operation table. So in these scenarios, we can definitely use high doses of midazolam, fentanyl, thiopental sodium, or propofol to reduce the CMR O2. At this point, I will share another case. 2 months back, one 13 years boy was posted for aortic valve replacement. He was having congenital severe aortic stenosis. He was not able to walk even 2 steps. So I was already anticipating that this patient may have cardiac arrest while induction. So when I put central line, connected inotropes, and then inserted arterial line, and I induced him. After induction, though his blood pressure was normal, he started having ventricular fibrillation. At that point, I induced him with 200 milligrams of 200 micrograms of fentanyl and 5 milligram of midazolam. His weight was only 35 kg. So this was a high dose for him, but he required 56 DC shocks. And with continuous CPR, his chest was opened, he was put on cardiopulmonary bypass, and aortic valve replacement was done. So I was not very sure, but I thought that I have done a good job to protect his brain. And fortunately, next day he was extubated. He had only one episode of convulsion, which was treated with medical management, and he was discharged on 8th day. So as an anesthesiologist, if we face cardiac arrest on table, then definitely we should try to use our routine induction agents so that we can decrease the cerebral metabolic requirement of oxygen. Now, if we implement all these strategies, still there will be few patients who will not have normal brain function. These neurologically devastated patients will require very high intensity ICU care. Vegetative patients cause burden to healthcare system, patients' family, and society in general. So we have to identify these patients, and we have to resource allocation is very important, because those patients who are vegetative will take away a lot of energy from ICU staff. So we can categorize these patients, we can see whether these patients will have good prognosis or not. There are few pre-cardiac arrest factors like advanced age, severe diabetes, then septic patients, patients with metastatic cancer, then poor lifestyle, and patients with stroke. These patients will usually not have good prognosis after cardiac arrest. During cardiac arrest, if there is long duration between the collapse and start of the CPR, if the quality of CPR is not good, once that patient reaches to the hospital and he is intubated and put on ventilator, and if you monitor the EtCO2 and EtCO2 is less than 10, then definitely the prognosis of this patient will not be good. If the patients with ventricular fibrillation don't get shock early in their treatment, then the prognosis will be poor. So in these patients, the brain function will not be normal. So you have to decide whether to go very aggressively in these patients or not. Post cardiac, you have to, after resuscitation, we have to check whether their brain function is normal or not. So initially, these patients will get receive anticonvulsion, then we will give sedation and muscle relaxant. So it is not a good idea to test their neurological function in first 24 hours. But on third day or maybe after 72 hours, we have to check for pupillary light response, corneal reflex, or the motor response to painful stimuli. If these reflexes are absent, then the brain function is not normal. Status myoclonus is a reliable predictor of poor outcome. Before doing all these tests, we have to stop all the sedative and relaxant so that we can have proper testing. I will tell in short regarding one more case. 10 years back, when I just started my practice, there was one physician, young physician, who had cardiac arrest at his home. And he was shifted to his own hospital, where at least 10 physicians gave CPR for almost 80 minutes. And then he was shifted to the hospital where I was working as an anesthesiologist in cath lab. There, angiography was done and he was diagnosed to have 100% LED block. Immediately angioplasty was done. On table also, he required another 20-25 ADC shocks. But unfortunately, these patients, this physician had both frontal lobe infarct. So now, after 10 years, he is alive, but he is not able to live a functional life. His family has to take care like a child. So these patients will have very poor quality of life, as well as there will be emotional and financial burden to family as well as the society. So we should take care to prevent brain injury at all costs. As an anesthesiologist, we know how to do aggressive management to salvage the brain function, and we should not hesitate to use high doses of fentanyl or midazolam even in hypertensive patients, only to save his brain. If the brain is normal, then only these patients will have good functional life. Otherwise, those vegetative patients in whom you have successfully saved his myocardium, but his brain is not functioning, then definitely it is not a welcoming outcome for patient as well as for the relatives. So at last, I would like to conclude with a few words like we have to give effective COLS or basic life support to all the patients till they reach to the hospital. Once they reach to the hospital, we should aggressively give advanced cardiac life support. And as an anesthesiologist, we are the one who are capable of doing this. In all cardiac arrest patients, unless we find out the cause and treat that cause, it is not possible to save patients. So so point of care ultrasound is very important. So each and every anesthesiologist should learn this technique. I think it is not very difficult for anesthesiologists to learn the basic echo. We should be well acquainted with the procedures like central line and arterial line, so that we can perform these patients right away in the casualty, and we can give better treatment in the form of inotropes, as well as frequent monitoring can be done through the arterial line sampling. As I already mentioned, that door to balloon time should be restricted to less than 90 minutes. Once the patient is stable, then at earliest possible opportunity, we should do the neurological assessment so that we can do the resource allocation to the neurologically intact patients. And this all, it's about team. Even if I am a trained anesthesiologist, even if I am a cardiac anesthetist, I know each and everything, but unless I have a good team, and I cannot save the patient. And my friend is saved not because of me, but it is because this whole team was very geared up They knew what to do, how to help the patient. And one more thing is that when I shifted this patient to United Sigma Hospital, no person from the hospital management inquired me or relatives regarding the finances. No one asked who will pay the bills of 1080 place, because you know that 1080 place will cost around 40,000 rupees. No one asked who will pay for his angioplasty. I know it is very difficult to manage finances, but unless we treat these patients aggressively, we will not able to save these patients. So not only the clinical persons, but even the management level is there in this team. And unless they give a green signal, we are not able to give 100% to these patients. So it's all about team. As Helen Keller quoted, alone we can do so little, together we can do so much. So in future, we should try to improve the medical services. I think in India, we don't have emergency medical services at all places. Now at few medical colleges, they have already started post-graduation in emergency medical services. I think in coming years, these services will be available at villages also. And being an anesthesiologist, we should try to train each and every staff of the hospital. And also we should try to visit the schools and colleges where we can teach this COLS to all the students. So it is very easy to have good imprint of COLS on the students' mind. So I think that COLS propagation will happen only if we reach to the schools and colleges. So with this, I conclude my presentation. I thank again ISA City Branch Nanded for giving me this opportunity. Thank you.
Thank you, sir. It's for a very great thing that you are able to help your friend, and that's something like you did for his family also. They are in very great debt to you. And basically, sir, how you think that you should not intubate in this case, and you will go ahead with COLS only?
Actually, when I reached to his home, his relatives were crying. I also got emotional because he was my friend. He is working with me since last 5 years. So with these emotional outbursts, I was myself was in dual mind whether to intubate him or not. But then I thought that if I waste my time in intubating, then I will lose initial important 5 minutes, because those are the 5 minutes where most of the damage will happen to the brain. And without thinking much, I thought that this United Sigma Hospital is very near from his home. So I will be in better position to treat him at United Sigma Hospital. So therefore, I decided not to intubate and immediately rush to the hospital. I think that is the thing which saved his brain.
Sir, just not to mind about this. That this patient is at his home and still you want to shift him to the hospital. Better you told that your kit is in your vehicle, so you can call for help from your hospital and you can visit it at home only. Is that thing in your mind after the course of the event?
But in that case, I would have lost another 5 to 10 minutes. Even if I would have called my group members, they would have taken another 5 to 10 minutes to reach to the spot. And one more problem was that as I was knowing his home, but my colleagues, they don't know his address. So it will take another 5 to 10 minutes, and that are the most precious 10 minutes. I think initial 5 minutes are very crucial. So
Yes, sir.
without any
Your write-up, yes. Go
without
ahead,
any
sir.
help, I think it is the best strategy to give chest compressions only. And once you reach the hospital, then you can do other things. Like once I reached the casualty, I didn't give chest compression. That then chest compressions were given by the casualty staff. Then I intubated him. First thing I did, I intubated him. Then I put the peripheral 2 lines I put, and then I started inotropes. So advanced care can be given, I think, only in hospital setup.
Yeah, your write-up was heard, was seen by me in WhatsApp group, our IMSCSA CPR group from Sujeet, Zine madam. She shared your event. There, one line was mentioned that the driver missed the angle or divider, something like that. That was that write-up. Can you elaborate on that?
Actually, I reached there after I think 5 to 7 minutes after receiving the call. So meanwhile, on the way to his home, I received 2-3 calls from his wife as well as from his father. And the last call, his father told me that he is breathing heavily. So I knew that this is a catastrophic event, and probably he will have a cardiac arrest. So I was anticipating it. But when I reached there, all the relatives and the neighbors were there, and they also sensed that this is an emergency situation. So they were also ready to shift him. Already they had one car there standing, but that was a small car. So I requested that I will shift him only through my car so that I can give chest compressions. And I requested that please someone drive my car. So someone from the crowd said that I know driving and I will drive. So I thought that he is from the same locality and he knows where is the United Sigma Hospital, but he was not from the same locality. Actually, he joined as a security person there, and it was his first day of duty. So when I told him that we want to go to United Sigma Hospital, on the way he asked me from where I should go. Then I was giving chest compression, and I was also directing him. So we have to go from this road and that road. But unfortunately, he reached to a dead end. So already I was in stress to save my patient's life. And this fellow was wasting time. Then I shouted at him that please take vehicle from the bridge and we will reach to the hospital. Then it took another, I think it delayed maybe 2 to 3 minutes, but he safely reached a hospital. And then once we were in the hospital, then because I was working there since so many years, and all the staff and RMOs were knowing me, so further progress was smooth.
Sir, one question from, I think, raised by hand by Ashwini Indurkar, madam. Madam, please unmute yourself and ask question to sir. Dipen, please connect to madam.
Hello.
Dipen, Ashwini madam has raised hand. She wants to speak some or ask question. Ashwini madam, you can speak now.
We have allowed her to talk.
Yes, yes, yes. Please unmute. Her. Dipen, can you unmute her?
Have already allowed her to talk. She has to unmute herself.
Yes, yes, yes. Ashwini madam, please unmute yourself and ask question. Meanwhile, we will take on another question. It's anonymous attendee. How long can we give COLS without giving ventilation?
Actually, COLS should be continued till you reach to the hospital. So the time duration is not defined. It may take 5 minutes, or you can give COLS for a longer duration till you reach the hospital.
Without ventilation.
Yeah, definitely.
Our IRC guidelines wise, it's 120 per minute and 30 compressions of 5 cycles.
Yes. You should try to shift the patient to the nearest possible hospital. So it will save time. Once patient reaches to the hospital, then there you can give advanced cardiac life support. So our aim is to save patient till patient reaches hospital.
Or when the resistor is exhausted doing COLS procedure, that time also he can live.
Actually, it is very difficult to give chest compression by a single person.
Yes,
I myself was tired while giving chest compressions. I gave chest compression maybe for 10 to 15 minutes, but it is a very demanding job. And I think the first thing in COLS is that call for help.
Yes.
Once you see that someone is lying there who is unconscious, he's having cardiac arrest, then immediately call for the help and then start the chest compression, so that once someone reaches the spot, you can always exchange hand and give one by one chest compressions.
So it's a single-handed person, he can do for 5 cycles and then stop or do continue till he exhausts.
Yes. If you are fortunate enough and there are 3-4 people, then definitely you can rotate and continue chest compression till a patient reaches the safe hands of hospital staff. Once patient is on hospital, then there is no limit how long you can give CPR. Few years back, our team member, Dr. Ramdas Khodwe, he witnessed a cardiac arrest of an X-ray technician in ICU. That fellow collapsed in front of his eyes. So he immediately intubated and they gave advanced cardiac life support for 90 minutes. And then he was with continued CPR, he was shifted to cath lab, and he had his RCA 100% block. He was underwent angioplasty, and fortunately his recovery was so smooth. He was extubated in another 24 hours. He is still working in that hospital. So even 90 minutes chest compressions or the CPR can save the patient. So time duration is not the factor we should look after, but effective CPR is very important.
Sir, even in you did a CPR in a running vehicle, and that cushion of the seat is not that hard. That our IRC and even ASS Society also mentioned that hard surface to be there.
No,
And,
actually, mine is a CR's car. So back seat, I think all cars back seat are hard enough where you can give effective chest compression. That was not the problem. The only thing was that my height is around 6 feet. So I was not able to stand properly and give chest compression. So it was very difficult to give chest compressions in a running car, but somehow I managed.
I think it's like movie scene, and you did that. And I never seen like this picture in my mind. Even
I think nobody should face such problem in his life. If there is an event with our dear ones, then it becomes very challenging emotionally for us to treat him. So we have to keep the calm, at the same time we have to treat him. So it is really challenging, and I was actually drained out after doing everything, and Once the patient was shifted to CCU, then I went to his home. I consoled his parents, and immediately I switched off mobile and took rest for another 4 hours. So that was very challenging for me.
Really exhaustive work you did in that period and that moment. You have that much energy, and really appreciate your work. So, question from Dr. Devendra Lakshman Bhosle, sir. He's asking, can we still give a try for ACLS for the patient coming to emergency room and recorded with flat ECG?
Even if patient is having a systole, you are not able to record any rhythm, I think you should try to find out the cause. And unless you find out the cause and treat the cause, you will not have ECG. So always try to find out the cause. There are many times metabolic causes, like the patient is having hyperkalemia. And unless you treat hyperkalemia, patient's ECG will not revert to the normal sinus rhythm. So I think that is the reason I told that the point of care ultrasound is very important in casualty or in ICU, even in operation theaters. Many times we hear that there is some cardiac arrest or some young patient died in operation theater. So I think even our colleagues, they don't give CPR for long duration. So only continuing CPR is not of help, but you have to, while continuing the CPR, you have to try out to find out the cause. And once you know the cause, then definitely you can treat that cause and patient will have some signs of life. Particularly in young patients, don't lose hope.
Yes,
Young
sir.
patients will respond very well. Then another category is pediatric patients. The pediatric patients will tolerate hypoxia for a longer duration, and their recovery is also very good. So I think in pediatric patients and in young patients, particularly those patients who are in operation theater where anesthesiologist is available, I think we should give our best efforts to save the patient even for longer duration. As I already told that already our colleague had given CPR for 90 minutes and that patient is still working. This happened, I think, 8 years back.
Without any neuropathic injuries.
He was not having any neurological deficit. Once he was extubated, without asking any question, there was one ward boy standing just besides him. He immediately told us that this fellow owes 2,000 rupees to me. So that was the sharp memory there. Apart from that incidents, he was remembering each and everything.
Zakir sir, Zakir Patel sir, our ex-GC member, is asking, actually he's appreciating your work, sir. Excellent management and presentation, Sujeet sir.
Thank you, sir. Zakir sir, thank you very much.
I think from our ISA Nanded City branch member, Tejas Bhandari. Tejas, you can even unmute and you can ask also. If you want to ask the question, can I? Tejas is asking, sir, you said ACLS can be given for long time, but after treating all the causes, if still we don't get any rhythm, then how long should we continue? Sir, I want to share that he did more than 100 cardiac cases in Nanded city. He is the first cardiac anesthesiologist from ISA City Nanded branch. He also presented one case meet in our platform, sir.
Great. I congratulate Tejas for completing 100 cardiac cases at Nanded. Even if we don't get rhythm, I think we can continue CPR, particularly in young patients. As I already told that if the pre-cardiac arrest factors like advanced age, patients is having severe sepsis, or patient is having metastatic cancer. In those patients, the survival will be poor. But if you are able to find out the cause and treat the cause, then I think most of the patients will revert to the normal sinus rhythm. And the second problem in Indian setup is that we don't have ECMO available in all centers. So ECMO is the one thing which can salvage young patients, particularly young patients. So, but I think in Marathwada, ECMO is available in Aurangabad, and apart from Aurangabad, rest of the cities don't have ECMO, and it is very costly affair. It also requires a cardiac surgeon, a cardiac anesthesiologist, and a perfusionist to run ECMO in these patients. But even if it is not available right now, in future, we can hope that each and every city, at least district places, will have ECMO at few hospitals, so that young patients can be saved.
Tejas, you want to
still,
speak? Yes. Yes.
Still any definitive time? Like a lot of time we have seen in casualties or in critical care units, we give all the possible things, like we treat acidosis, temperature issue, hypokalemia, all the possible H and T's, but still there we don't get any rhythm.
In those patients, I think this ultrasound will help to find out the cause.
The LV function, if again is less, there is no heart movement.
Apart from heart, there could be other causes also, like patient may have abdominal bleeding from where he has lost maybe few liters of blood, you don't know. Many times there is retroperitoneal hematoma, and patient has lost maybe 2 liters or 2.5 liters of blood, but there are no external signs of hemorrhage. So in these cases, we randomly treat that patient for cardiac arrest, but the real culprit is the hemorrhagic shock. So basically, these patients will require massive blood transfusion, and only then we can save these patients. So focus is very important.
Tejas, you got your point?
Okay, sir.
Tejas is our junior and is really doing great work in cardiac anesthesia.
I am happy to know that Tejas is doing cardiac anesthesia at Nanded. Few years back, we were there in Nanded. We regularly visited maybe once in 15 days to do cardiac cases. But now with availability of Tejas, now they must be doing cardiac cases daily. That is a good thing.
Yes. Yes. Yes.
Yes.
Sir, in young patients, you said, but somehow in our Indian scenario or Marathwada scenario, there a lot of drapes are there on patients, and you don't find out early that respiratory depression or something like that. Even you are put on O2 also, and sudden desaturation and arrest happening, and that time it's a very dicey situation. It's to be intubated first or to do COLS first. At that time, even and sometimes that in OT that non-skilled persons are more. Sometimes someone just joined the OT or who is good in these things, he is assisting the surgeon. That time it is very difficult to do COLS or intubation practices in these situations.
I think that is the point where we can score much. As an anesthesiologist, we visit many hospitals, and we also see that there are many smart persons available in operation theatre. They may be class 4s, they may be OT assistants, or they may be nurses or brothers. So these, you have to pick up these smart people, train them in COLS, BLS, and also ask them to do certified course of ACLS. So these patients, if you get trained at least 1 or 2 person in each hospital, they will help you in such scenarios. Without team, you cannot help patients. So for that, apart from upgrading our own knowledge, apart from increasing level of our skills, we have to train these hospital staff. As an group in Aurangabad, wherever we give anesthesia services, we offer these COLS courses free of cost to all the hospitals where we give anesthesia services. So we have our own mannequin, and in few hospitals we are doing this COLS refreshment every 3 months. So that is the thing which will refresh knowledge of all the OT staff. Even the security guard who is at the door of the hospital, he is also included in the training. Many a times we see that we are busy in operation theater, and surgeon is also with us in operation theater, but his OPD is full. And in that OPD, there are few patients who will collapse. It is not that they have cardiac arrest, but they will have vasovagal. And unless you treat them effectively, they will not survive. So these simple things like training the hospital staff will help not only patients, but they will also help us to manage the patients effectively.
Yes, really, this thing should be learned from you, that teach our colleagues and surrounding staff. That is a very good point, sir. I think we can conclude now. It's 9 o'clock, and it's very good talk with you on CPR week.
Thank
Any
you,
questions
Sachin.
from? Still, I'm asking to audiences. Any question, or any? Can you raise hand also, or you can type in question box also that any question you want to ask to sir. Okay. I think no questions. No question from audience. I feel so.
Thank you,
Sir,
Sachin. You give me
yes.
opportunity, and the most important thing is that you suggested the title. That title made me think, and I read few more articles, and it opened a totally new vision even for me. So I really thank you for that, and also to the ISC City Branch Aurangabad for giving me this opportunity. I did my MBBS from Nanded, so I have special feelings from Nanded. So I am very happy to be with you. Thank you.
One last case was mine in the Nair. I did my PG in Nair, so basically, and that time in my second year, I'm doing posting in OBGY, and one case was done of a technician, X-ray technicians related. It was LSCS, and done at 6 o'clock or 7 o'clock in the evening. And that section was done peacefully. The thing was happened. And after closure, we are just gossiping with each other and chit-chatting. And that time, sudden cardiac arrest was happened. And we have that time with us one lecturer, senior resident, junior resident, all these teams were there. So we immediately started doing CPR, intubation, everything. And we shifted this patient from, I think, half kilometer, like that campus is away from ICU setup. So
Okay.
main complex and OBGY complex was different that time. So we shifted this patient with AMBU and that CPR with our 2 residents, and shifted to the ICU. And when we put it on the ICU bed and we plug in the ECG leads, that ECG is coming on. And in OT of OBGY, that was the flat line. And that was my memorable thing. And second is yours, that you did this. These miracles are happening here and will happen again and again. With this note, I will conclude this session, sir.
Before concluding, I would like to add one more thing. As you said
Yes.
that you noticed ECG in ICU. What
Yes,
I
sir.
see in not only in Aurangabad but in many places wherever I visit, I usually try to go to the local operation theater and talk to the anesthetist there. What I have noticed that in most of the operation theater, the ECG monitoring is available, but it is rarely
Yes,
used. Even
yes.
people will say that for cesarean section, there is no need of monitoring ECG. Only pulse ox and NIBP will do. But I think
Yeah.
we should monitor ECG in each and every case. Even if it is a local standby case, you should attach ECG to the patient and monitor. That is the thing that will alert you regarding some catastrophic events few minutes early, and those few minutes will save patient, you as well as the surgeon. So that is very important thing, and we should monitor ECG each and every patient.
Okay, sir. This is a really good thing, sir. Even I am also, you said in for local also. So most of the time we use SpO2 and heart rate is enough for, but now I can suggest to all my colleagues and city branch members to use ECG regularly in each and every case. It is major or minor, nothing is there. This life is major for us and for relatives also.
Thank you, Sachin.
Thank you, Lord sir, from ISA City Branch Nanded. Once again, I will say thank you. This is our ISA City Branch case meets. This one is our aim to do Platinum Jubilee celebration with Silver Jubilee celebration of ISA City Branch Nanded. So we'll meet next week with Vibhavari Naik ma'am. She will speak on cleft surgeries and cleft palate, recent updates and newer things. She will very much talkative like sir also. So, and sir is a student of Vibhavari Naik madam. So it was like guru and shishyas are coming
Yes.
on our platform simultaneously. So thank you, sir. It's I'm really happy to talk with you, and from this way we can meet each other on this platform. Sir.
Thank you. Thank you.
Start, sir.
Yeah. Bye.
Bye, sir.